This is Mon Health Talk, a weekly program focusing on the dedicated physicians, nurses, and staff at Mon Health, the region's premier community hospital system. People with skillful hands and bright minds using state-of-the-art technology. We don't just practice medicine, we care for people like family. That's why at Mon Health you can feel the difference. Once again, welcome to this edition of Mon Health Talk.
Good morning. Welcome into the program, Mon Health Talk. I'm Dave Wilson. This morning, our guest is Dr. Allison Cihla, critical care and pulmonary physician, Mon Health Preston Memorial Hospital. We'll be talking about Lung Cancer Awareness Month. But first, let's welcome in Dr. Cihla. Good morning.
Good morning. Thanks for having me.
Well, thanks for taking some time. We'll get into the subject at hand. But first, we must talk about you just a little bit. Tell us about your background, where you're from, and your education, how you ended up with Mon Health.
Sure. Well, I'm originally from a small town just west of Cleveland, Ohio. That's where I was born and raised. I went to medical school at the University of Toledo in Toledo, Ohio, and then found myself here in Morgantown for residency. I completed my residency in internal medicine at WVU, and then I stayed on and completed a fellowship in pulmonary and critical care medicine also at WVU.
So how did you end up with Mon Health?
After I completed my training, they were looking for a person to come and work there. I worked at Mon General at the main campus there for a couple of years, and then I moved and am working currently at Preston Memorial Hospital. I really like the setting there. The people are wonderful. It's a very small community feel, which I really like, and feel like I'm able to make a difference and help people without making them have to travel, so far to get to a larger hospital.
Always curious with our guests, but what led you to the medical field?
I think it was my family. My grandmother had some health issues that I remember when I was growing up, and it made me want to get into medicine so that I could help people.
We're talking to Dr. Allison Cihla this morning, critical care and pulmonary physician, Mon Health Preston Memorial Hospital. November is Lung Cancer Awareness Month, and if you could generally, I don't know if this is the right way to say it, can you describe lung cancer, because it's one of those that can go undetected for a very long time. So let's just kind of lay the foundation. Generally, what are we talking about when we mention lung cancer?
Sure. So like any type of cancer, you have some abnormal cells that are growing someplace in your body. And it starts out as one cell, two cells, and then it grows and these cells divide and they become bigger and they take over more area in your body. And so like you said, lung cancer and other types of cancer can go undetected for a period of time. And because of that, it gives it a chance to really grow without having symptoms. And so sometimes patients don't know that they have a problem until it's grown and it's become of a significant size.
So as we get older, we get colonoscopies and we get, and women will get breast cancer screenings, and there are certain things you look for. I don't believe I've ever heard anybody say that like a lung cancer screening's on that normal regimen. So how do you detect lung cancer, or how do you look for that?
Sure. Well, previously what we did is unfortunately we had to wait until patients developed symptoms. They would come in with a new cough that just wasn't getting better. They would, sometimes be coughing up blood, or, in some unfortunate cases, this lung cancer had spread to other parts of the body, and that's how it was detected. Several years ago, they were looking into this because we had a pretty large proportion of our lung cancer patients dying from lung cancer. And so, as with everything else, how do we head this off? How do we prevent this? And multiple studies were done trying to find the best way really to look for lung cancer at an earlier stage. And what we came up with was the lung cancer screening program, which involves getting an annual low-dose lung cancer screening CT scan or a CAT scan of the chest. And what that means is that the low dose part of it means that you're getting a lower dose of radiation than you would get with a typical CT scan. And the dose of radiation, again, it's lower so that we don't cause any other issues from the radiation, but it's high enough so that we can see what's going on in the chest, and we can look for early signs of abnormal cells or abnormal growth that may be amenable to treating at an earlier stage and hopefully curing, giving patients a better chance at cure.
I want to talk about that a little bit more in depth coming up in the next segment. Certainly when we're talking about lung cancer, I think most people closely relate lung cancer to smoking, but is that always the case?
It's not always the case, but especially in the United States, we do see that about 80 to 90% of our patients that are diagnosed with lung cancer, it is related to smoking. There are some types of lung cancer that are more likely to be related to smoking, but there are other risk factors and other exposures that can also cause cancer. But we do see about 80 to 90% is associated with smoking.
What are some of those other risk factors that maybe people don't think of?
Sure. Well, in addition to the patient themselves smoking, secondhand smoke does play a role, less than a primary smoker, but it can still affect that. We also see other exposures such as radon, other occupational exposures like asbestos, arsenic, diesel exhaust, silica. Those are some of the occupational exposures that some of our patients in this area may have that would put them at a higher risk. We also know that there is some degree of personal and family history. If patients had cancer before, or if they have a strong family history of lung cancer, that could also play a role. And then one of the other things that we can see is that if a patient has received radiation to their chest in the past, this does put them at a higher risk. So this would be patients that may have had like a lymphoma where they needed to get radiation to the chest. That would put them at a higher risk just because of that high dose radiation exposure.
Sounds like if you fall into one of these categories, whether it's because of your job or you've been around smokers, you are a smoker, it sounds very important that you add the lung cancer screening to the list of regular checkups, list of regular screenings that you take part of so you can catch this early if it pops up.
Currently, the recommendations for this lung cancer screening are really targeting smokers. Again, 80 to 90% of lung cancers are found in smokers. And so the studies that they did really looked at patients with a smoking history, patients that were current smokers or patients who smoked in the past, and trying to really focus on that particular group. There are other people that we definitely want to be aware of their past occupational history, but might not necessarily fall into that particular guideline. There are, other studies and tests that we can do for those folks. But it's definitely important that if you have any of those risk factors, that you do discuss it with your physician and find out if that's a good test for you.
Been doing this show for a few years now, and I've learned maybe one or two things along the way. And one of them is when it comes to cancer, the earlier you can detect it, the easier it is to treat and the better the prognosis is. And I would be inclined to believe that would be the same. The earlier you can detect lung cancer, the easier it is for you to treat, and the easier it is, and the better the prognosis for the patient.
Absolutely. If we can find a spot when it's measuring only an inch versus 5 inches or 6 inches, or whether it's spread, it's absolutely easier to treat for the most part for most patients. And so, again, we start these screenings early. We start it at age 55. They just recently changed the guidelines. It was at age 55, and they recently moved them down to age 50. So, we're starting to screen these patients early because we do want to find things at the first sign that something's wrong rather than waiting until it's spread. All
right, we're going to talk a little more specifically about the low-dose CT scans. We come up on the other side of the break. Our guest this morning is Dr. Allison Cihla, Critical Care and Pulmonary Physician, Mon Health Preston Memorial Hospital. You're listening to Mon Health Talk on WAJR.
Now back to Mon Health Talk, a discussion of the issues, people, and procedures in healthcare today. If you have a question for one of our healthcare guests, call now at 304-296-0041.
Our guest this morning is Dr. Allison Cihla, critical care and pulmonary physician, Mon Health Preston Memorial Hospital. November is Lung Cancer Awareness Month. And Dr. Cihla, we've kind of been talking a little bit here and there throughout the conversation about the low-dose CT scans. You kind of went over what those are. Go through the recommendations again. Who are eligible for these cancer screenings?
Sure. So people that are eligible are people that are between ages 50 to 77, that are current smokers or who have quit smoking within the past 15 years, are completely asymptomatic, which means that they don't have symptoms of lung cancer currently. If you have symptoms of lung cancer, that would put you into another type of CT scan that we'd want to do. And then also these patients have to have had a history of smoking at least 20 pack years. And so what that means is that they've smoked a pack of cigarettes a day for 20 years, half a pack of cigarettes a day for 40 years, 2 packs of cigarettes a day for 10 years, but they've had to have a significant smoking history. And if you meet all of those, excuse me, if you meet all of those criteria, then you would be a candidate for the low-dose CT scan.
What makes this screening appropriate for someone, like you said, with all those risk factors, but they are asymptomatic? Why is this the preferred option now?
Again, it's a low-dose CT scan, which means you're getting a lower dose of radiation. And so it's appropriate to do these and to do these on a regular basis. The current recommendation is that you have one every year until you don't meet the criteria anymore in order to screen for lung cancer. So this is not somebody that is having symptoms. If you had symptoms, we would want to do what's called a diagnostic CT scan. So this is just a screening CT scan in order to really just get a quick look at a lower price point for our patients to see whether there's any abnormalities or anything that needs further investigation or monitoring.
Is this something that you would ask your primary care physician about, or something that they would probably recommend if you're in all of those, you meet all that criteria? But this sounds like a discussion you would want to have with your primary care physician, right?
Yes. Yeah, your primary care physician is the perfect person to speak to, or if you see a specialist, if you are already seeing a pulmonologist, they would also be a good person to speak to about this. But they're able to order these. We do them both at Mon Health Medical Center. We also do them at Preston, as well as our other hospitals within the health system.
Is that something that would have to be ordered by your PCP, or get a referral, or can a patient reach out to you in your office directly?
So it should be ordered by somebody who's taking care of you. There is some counseling that needs to be done for patients. For example, we want to make sure that if we're going to take on this screening process, that it's something that the patients want and that the patients are willing to go forward with further evaluation and monitoring and possibly treatment if they need it. And what I mean by that is if I have a patient in my office that says, you know what, I don't really care what is happening in my chest because I'm not going to do anything about it. I've made up my mind that if I, were to develop cancer, I don't want any treatment. I don't want chemotherapy. I don't want radiation. I don't want surgery. That's a conversation that we need to have. You need to have with somebody who knows you and who can sort of talk to you about those things and give you guidance on those options and what would need to happen. And so it should be ordered by somebody that does have that relationship with you and that can answer those questions for you. So, your primary care physician is always a great place to start. If they have any questions, they can get a hold of the pulmonologist to ask, more detailed questions, or the radiology department as well.
Talking to Dr. Allison Cihla this morning, critical care and pulmonary physician, Mon Health Preston Memorial Hospital. November is Lung Cancer Awareness Month. And for someone who does develop lung cancer or lung cancer is detected, can you briefly give us an overview of, and I know each patient's very different and you have to come up with an individualized treatment plan, but broadly speaking here, can you give us an overview of what a treatment plan would consist of?
Sure. So it would depend on what we would find on the CT scan. There are some spots on the CT scan that may just look a little bit abnormal, and sometimes the course is to monitor those with additional CT scans. Sometimes patients would need to get a biopsy or a sample of that tissue. And if patients were diagnosed with lung cancer, then usually that is managed by an oncologist or a cancer specialist. Depending on the type of cancer that was found, there are generally two major types of lung cancer. One is small cell lung cancer, and the other is non-small cell lung cancer. Small cell lung cancer is almost always related to smoking. Non-small cell lung cancer is a type of lung cancer that generally is more common than small cell. Usually about 80% of our lung cancers would fall into that category. They usually grow and spread a little bit more slowly than small cell. Small cell lung cancer, because of its rapid spread, generally is treated with chemotherapy. And sometimes there are some other options for non-small cell lung cancer. But again, as you mentioned, it's really an individualized treatment plan for each patient. It depends on the location. It depends on the size. It depends on whether there's been any spread as to what the best treatment plan would be for that patient.
Got about 30 seconds before we have to wrap up. What's the one thing you want listeners to take away from our conversation today?
Oh, that's a hard one. I would say, if you are a smoker and you're thinking about quitting, please really consider how you can quit. We know that smokers are 15 to 30 times more likely to get lung cancer or to die from lung cancer than non-smokers. So if it's something that you've been considering, please think about it. And if you are a smoker, please reach out to your primary care physician or your pulmonologist to see about if you need to be screened.
Our guest this morning, Dr. Allison Cihla, critical care and pulmonary physician, Mon Health Preston Memorial Hospital. Thank you very much. Appreciate the time.
Thank you.